Hello, everyone, and welcome to the RSNA Radiographics Podcast. I'm Jennifer Weaver, a musculoskeletal radiologist at Vanderbilt, and I am excited to have two special guests with me today, Dr. Mihra Taljanovic from the University of New Mexico and Dr. Imran Omar from Northwestern University, who co-authored the article Musculoskeletal Manifestations of COVID-19, currently described clinical symptoms and multimodality imaging findings. We all know that COVID-19 has had a profound impact on our world, initially presenting with respiratory and hematological symptoms. However, over time, we've come to understand that COVID can also affect other organ systems, including the musculoskeletal system. In today's discussion, we will focus on the musculoskeletal manifestations of COVID-19 and their imaging findings. Dr. Taljanovic, could you please share with us some insights into the osseous manifestations of COVID-19?
Sure. Articular or periarticular pain in COVID patients may be caused by osteonecrosis, which has been reported in about 5 to 58% of patients. Osteonecrosis in COVID patients is thought to be caused by corticosteroid administration, hypercoagulability, vascular inflammation, and bone resorption through stimulation of ACE2 receptors. Corticosteroid therapy, especially in high doses over prolonged periods, is likely the leading cause of osteonecrosis in severely ill patients who require ventilation. Other risk factors include male sex, use of multiple types of corticosteroids, alcohol or tobacco use, and cardiovascular as well as cerebrovascular diseases. Periarticular osteonecrosis of the femoral or humeral heads may be incidentally diagnosed on CT or MRI examinations in COVID patients performed for unrelated reasons. An interesting and unusual phenomenon seen in COVID patients are COVID toes, which are chilblain-like or pernio-like lesions. These localized erythematous eruptions commonly affect the toes and are typically seen in teens and young adults with mild COVID symptoms. The exact cause of COVID toes is unknown, but we believe that vascular and immunologic factors such as vasospasm, perivascular lymphocytic aggregation, endothelial damage, and fibrin microthrombi could be involved. These lesions are usually diagnosed clinically, but may also be associated with osteonecrosis of multiple phalanges in the feet, which can be detected by MRI. Involvement of multiple phalanges is highly unusual and has not been routinely seen in other disease processes.
Thank you, Dr. Taljanovic. Dr. Omar, can you discuss some of the muscle manifestations seen in COVID?
COVID can cause myalgias and fatigue, which interestingly may not correlate with the severity of disease. Muscle injury in COVID is multifactorial, involving immune-mediated damage, intensive care unit acquired weakness, toxic myopathy, and viral damage. So it's not surprising that we're seeing a wide range of presentations in our patients. We can classify these injuries into 4 main categories, and imaging assessment of COVID-related muscle conditions can, in some cases, limit the differential considerations and guide management. Non-inflammatory myalgias are self-limited and conservative treatment is appropriate. CT or MR imaging in patients with myalgias should show normal muscles without fascial thickening, fluid, or enhancement. Myositis, characterized by skeletal muscle inflammation, may show muscle and fascial edema on MRI with hyperintense signal on fluid-sensitive sequences and post-contrast enhancement. CT may also reveal muscle thickening and effacement of intramuscular fat and fascial planes, but MRI is better for depicting muscle edema, fascial stranding, and post-contrast enhancement. Supportive care is the main treatment for myonecrosis, which can cause severe pain. MRI and CT can reveal similar findings, with MRI being more sensitive in detecting myonecrosis. There are 2 MRI patterns of myonecrosis, type 1 and type 2. Type 1 myonecrosis reflects potentially reversible muscle ischemia and presents with similar MRI findings as myositis. This includes diffuse muscle and fascial edema with fluid-sensitive sequences and post-contrast enhancement. On the other hand, type 2 myonecrosis results from irreversible muscle infarction and is characterized by non-enhancing intramuscular areas with variable sizes and peripheral enhancement. Another interesting feature that can be present in the necrotic areas is called the stipple sign, which can appear as linear or curvilinear foci of enhancement. This could represent residual viable myofibers or inflamed crossing vessels. Finally, rhabdomyolysis is a severe muscle injury that can lead to acute renal injury due to myoglobinuria. This condition is often symmetric, with the predominant involvement of proximal lower limbs and profound weakness in COVID patients. Diagnosis of rhabdomyolysis is typically made clinically, but imaging can help assess the location and extent of muscle injury. MRI findings are similar to those seen in myositis.
Thank you, Dr. Omar. Dr. Taljanovic, we know patients with COVID often report joint pain. Can you discuss some of the joint manifestations that occur in COVID-19 patients?
COVID patients may experience joint pain caused by factors like synovitis related to post-viral inflammatory arthritis, rheumatoid arthritis, systemic lupus erythematosus, or psoriatic arthritis. Early in 2020, we saw many cases of new onset inflammatory arthritis in patients following COVID infections. Post-COVID inflammatory arthritis is an aseptic inflammatory joint condition, typically appears 1 to 3 weeks after onset of COVID and can persist into the recovery phase. It commonly affects a single or a few joints. We believe the development of post-COVID inflammatory arthritis is triggered by mechanisms such as molecular mimicry or bystander activation. Imaging findings of post-COVID inflammatory arthritis resemble viral arthritis from other infections. MRI may reveal synovial thickening, joint edema, and tenosynovitis. Periarticular osseous erosions are uncommon, possibly due to early disease stages or medications used for COVID treatment. Ultrasound with Doppler can also detect synovial thickening and hyperemia, indicating active synovitis.
Thank you, Dr. Taljanovic. It will be interesting to observe the long-term trajectory of COVID-related inflammatory arthritis in the coming years. Dr. Omar, could you tell us how COVID affects the peripheral nerves?
COVID-related peripheral neuropathies have been observed in critically ill ventilated patients and can have various causes, such as Guillain-Barré syndrome, toxic neuropathy, critical illness polyneuropathy, compressive neuropathy, and position-related neuropathy. Initially, viral infection was considered as a primary cause, but more recent evidence suggests other etiologies, since viral particles are rarely detected in the peripheral nerves or in cerebrospinal fluid through PCR testing. Guillain-Barré syndrome is the most commonly reported neuropathy associated with COVID, but its direct link is still debated. However, some centers did report increased cases of Guillain-Barré syndrome through the pandemic. Guillain-Barré syndrome in COVID can be para-infectious or post-infectious and usually occurs 5 to 10 days after COVID symptom onset. MRI is the preferred imaging modality for Guillain-Barré syndrome. Lumbar spine MRI can show distal spinal cord hyperintensity on T2-weighted imaging and nerve root thickening with surface enhancement in the region of the cauda equina and conus medullaris. Sometimes leptomeningeal and spinal nerve root enhancement may also be seen on MRI. Critical illness polyneuropathy is commonly seen in critically ill patients. This condition typically causes symmetric flaccid muscle weakness, particularly in the lower limbs. When it comes to diagnosing critical illness polyneuropathy, MRI is usually performed to exclude other potential causes. MRI may reveal non-specific muscle edema and fatty infiltration, which are more severe in the lower extremities. If necessary, this information can help guide muscle biopsies. COVID patients may also experience other types of peripheral neuropathies, including position-related, compressive, and post-infectious neuropathies. These neuropathies may be related to thrombotic microangiopathy. Prolonged prone positioning can cause traction and ischemia of peripheral nerves, which typically affect upper extremity nerves, such as the ulnar nerve and brachial plexus cords. This condition is often unilateral or asymmetric. Lower extremity neuropathies may involve the sciatic and common peroneal nerves. Localized nerve damage from microvascular injury, cytokine-mediated inflammation, and compression within fibro-osseous tunnels such as the carpal or cubital tunnels may also occur. High spatial resolution MR neurography and ultrasound are excellent imaging modalities for characterizing peripheral neuropathies. ultrasound is particularly effective for assessing peripheral nerves, as overall thickening of the nerves or thickened hypoechoic fascicles can indicate neuropathy. Newer microvascular Doppler ultrasound techniques can also detect slow flow intraneural vascularity, which can be a sign of focal nerve abnormality.
Thank you, Dr. Omar. Dr. Taljanovic, could you please provide some insights on long COVID and its potential manifestations on imaging?
Long COVID affects 10 to 20% of patients, typically younger individuals aged 20 to 50. It is characterized by persistent symptoms lasting at least 2 months, which cannot be explained by other diagnoses, and usually occurs 3 months after the onset of COVID symptoms. Many of these symptoms, including fatigue, shortness of breath, joint pain, muscle pain, spasms, and post-exertional malaise, may be related to the chronic impact of COVID on skeletal muscles. COVID-related myopathy can cause muscle weakness, spasms, exercise intolerance, decreased muscle bulk, and fatty infiltration. Other possible causes of muscle abnormalities in post-COVID condition include innervation, atrophy, deconditioning or sarcopenia, immune-mediated myopathy, toxic myopathy, and nutritional deficiencies. Imaging techniques like MRI, CT, and ultrasound can detect chronic muscle changes in post-COVID condition. MRI with Dixon technique can quantify muscle atrophy even when overall muscle size is not significantly reduced due to fatty infiltration. Ultrasound can detect focal or patchy muscle atrophy, while shear-wave sonoelastography can assess muscle stiffness and detect early abnormalities. Sarcopenia, which is usually associated with aging and deconditioning, may be more severe in critically ill COVID patients, affecting respiratory muscles and ventilator weaning. CT and MRI are commonly used to assess skeletal muscle cross-sectional area, while diaphragmatic dysfunction, seen in up to 76% of COVID patients, can contribute to dyspnea in long COVID.
Thank you, Dr. Taljanovic. We wholeheartedly endorse COVID vaccinations and boosters for their proven safety and effectiveness, with over 11.6 billion doses administered worldwide, covering 67% of the global population since December of 2020. The COVID vaccine has shown impressive results. However, like other vaccines, it can cause some reactions. Dr. Omar, could you brief us on these reactions?
Some reactions to COVID vaccination include localized pain and swelling at the injection site, as well as myalgias and arthralgias that usually last for a few days. In rare instances, musculoskeletal symptoms may persist for months or even become chronic. A common issue that may arise is shoulder injury related to vaccine administration, abbreviated as SIRVA or SIRVA, which can present as a rapid onset of shoulder pain and decreased range of motion within 48 hours of vaccination, often after the influenza vaccination as well. This is thought to be caused by a localized immunologic reaction to the injectate and may be more common in patients with prior sensitization. Improper positioning of the needle tip, especially in the upper third of the deltoid muscle, may contribute to this type of injury. It can affect various structures such as bursae, tendons, joints, or bone, and lead to conditions like bursitis, tendinopathy, synovitis, capsulitis, or osteitis and osteomyelitis. It's worth noting that shoulder injury related to vaccine administration related to COVID vaccination may differ slightly from other vaccinations. For instance, symptoms may develop 1 to 2 weeks after injection, and sometimes after just 1 dose. This suggests the inflammatory reaction may take some time to manifest in cases where there's no prior exposure. Additionally, newer mRNA vaccines, such as the Pfizer-BioNTech and Moderna vaccines in particular, may elicit a strong reaction when injected into non-target synovial tissues. One thing that's been commonly observed is enlarged reactive axillary lymph nodes, which can persist for a few months. Localized muscle edema with mild subcutaneous and fascial edema may be present for a few days or weeks following injection, but persistent muscle edema with localized shoulder pain may indicate focal myositis. There have been rare reports of other inflammatory musculoskeletal manifestations following COVID vaccination, such as reactive inflammatory arthropathies and flares of existing rheumatologic conditions, is suggesting a possible autoimmune response. Uncommon mild flares of existing conditions, such as rheumatoid arthritis or psoriatic arthritis, have also been described, although imaging studies of post-vaccine immune-mediated musculoskeletal manifestations are limited. In rare instances, Guillain-Barré syndrome has also been reported following COVID vaccination.
Thank you, Dr. Taljanovic and Dr. Omar, for your insights on the impact of COVID-19 on the musculoskeletal system. As radiologists, it's crucial for us to understand the imaging findings associated with COVID. We hope our audience enjoyed this RSNA radiographic podcast episode. Don't forget to check out the figures in the article. Thank you for joining us today.